I will briefly introduce. I am Dr. Marjan Yaghmai, Associate Professor of Medical Genetics at Oncology, Hematology, and Cell Therapy Research Institute, and head of the leading house for Iran-North America Academic Partnership. We are pleased to present the second part of the TOMS How I Treat Neurological Disorder series entitled How I Treat Neuropathy. This educational series was realized with help from the Neurology Department of Shariati Hospital, the Appraise to Raise team, and the support of Vice Dean for Educational Affairs of the National Campus. I would like to express my most sincere gratitude for the support and welcome to the educational program. It's a great honor for us to have you all here, at least virtually. Before we start, I would like to thank our invited speaker, Dr. Hadi Mohammad Khanli, and I'm now asking Dr. Nafisi, our first moderator, to introduce our valued guest speaker, Dr. Hadi Mohammad Khanli. Following that introduction, we will start the program. I hope you will find this webinar informative and helpful. Dr. Nafisi, please.
Hello, everybody. Welcome to this webinar. I would like to thank the Office of International Affairs of Tehran University of Medical Sciences and Dr. Yaghmai for organizing this meeting. The series, How to Treat Neurological Disorders. This is the second session. I hope you will enjoy this scientific meeting. I would like to thank our guest speaker, Dr. Hadi Mohammad Khanli. I will shortly introduce Hadi. Hadi is a double board certified physician in neurology and clinical neurophysiology, and he is currently working as assistant professor of neurology at City of Hope Comprehensive Cancer Center in California. Hadi is one of our graduates from Tehran University of Medical Sciences. He did a 4-year neurology residency in Tabriz University and then moved to United States. Over there, he started with a research fellow in age-related neuromuscular impairments at UCLA. And then he did a 3-year neurology residency at George Washington Hospital and 1-year clinical neurophysiology fellowship at the National Institute of Health. He's now going to speak about how to treat neuropathies. I would like to thank Hadi again and ask him to start his presentation.
Hello, thank you so much, Dr. Nafisi, for this kind invitation. And it's a really a privilege to be able to join this lecture and talk with you guys. I just want to tell that this is just I'm sure that most of attendees here may have such a huge medical knowledge about these topics that we are going to talk about, but I just wanted to mention, because we have different type of attendees, from medical students to attending physicians and subspecialists in this meeting. When I'm starting my slides, I'm going to start with definitions, and our main focus is going to be about autoimmune neuropathy, and of course the most popular one, the most this one, GBS. So, and then we're going to talk about CIDP, and then depends on how much time I'm going to have, end our slides talking a little bit about the neuropathies related to paraproteinemia. So as most of the attendees know about the definition of the AIDP or GBS, or acute inflammatory demyelinating polyradicular neuropathy, there are requiring features for diagnosis, which is the progressive weakness of left bilateral lower and upper extremity, which usually, when I was a resident, we name it as an ascending weakness, starting from distal lower extremity going up and involving the upper extremity, but it's not the case all the time. And the other main feature of the AIDP is areflexia in all weak muscles. The main thing that differentiate AIDP with other acquired demyelinating neuropathies is the progression should be over days to 4 weeks, because if it passed to 4 weeks, we are talking about the progression of the neurologic symptoms. And then plateau, then by definition is not AIDP. It goes to category of between 4 weeks to 8 weeks, gonna be subacute inflammatory demyelinating polyradiculopathy or SIDP. And if past this progression of the symptoms passes 8 weeks or 2 months, then by definition it's gonna be CIDP. So the other thing is mainly, as you know, the weakness in GBS are symmetric, and there are some associated symptoms like pain. It's more common than CIDP. Autonomic dysfunction can cause fluctuation in blood pressure, arrhythmia. And as you know, one of the first things that can help for diagnosis, checking the CSF and seeing the protein cell dissociation beside the electrodiagnostic and nerve conduction study findings, which usually appear at least a few weeks after beginning of the symptoms. And the only abnormal finding in the nerve conduction study initially when you diagnosing AIDP may be just very slight changes or no changes. So there are some red flags. If you see these red flags, you stop and think about other diagnoses than AIDP. One of them is sensory level. As you know, you should look for a spinal cord lesion or transverse myelitis when you see sensory level. If the patient had a significant bowel bladder dysfunction or severe pulmonary dysfunction at the beginning of the symptoms, this can be a red flag in diagnosis of GBS. There is no doubt there are cases of GBS that the patient comes with the respiratory distress, but having respiratory distress without having any weakness in the limbs is against this diagnosis. So you should be careful about that. We know about the prodromal symptoms of the GBS that can be secondary to an infection, but fever in the onset of the beginning, it's very, very uncommon. And you also should pause and think about other diagnoses. And lastly, if you do the CSF test and there's a plocytosis and white blood cell counts are more than 50, also, it should be a red flag. Regarding the systematic approach for management of the AIDP, beside the neuropathy part, there are multiple system involvement in AIDP that we should look for, and sometimes even more important, the GBS itself. For example, as we mentioned, because of the autonomic dysfunction, these patients are in high risk for having fluctuations in blood pressure or cardiac arrhythmias. So we should be very careful about giving some medications like beta blockers or atropine. And also we need to have a continuous cardiac Holter monitoring during the admission to detect any abnormality in heart rate. And if we require to give something for controlling, for example, blood pressure, we better use short-acting ones and not the ones with they are beta blockers, so like nicardipine. The other thing is treatment of the pain, because as mentioned, patient with GBS may have neuropathy that's with neuropathic pain, and usually we use the same medications that we use for all other neuropathic pains, mainly gabapentin, pregabalin, and in SNRIs, the one that we use very frequently here is duloxetine or Cymbalta. Regarding the pulmonary function, as we mentioned, like one of the most dangerous things about GBS is the respiratory failure and distress and requiring intubation and mechanical ventilation. We use the same rule for intubation. So first of all, we try to avoid emergency intubation as much as possible and do elective just intubation. So don't wait that patient to collapse completely and then do the intubation. For the using the, I think 20-30-40 rule, it's a good option for doing an elective intubation. What's the rule? 20-30-40 means like if the vital capacity is below 20 or MEP below 30 or MIP is below, MIP below 30, MEP below 40, then we should do the elective intubation. And one other thing is like, as much as possible, avoid like muscle relaxant, like such as succinylcholine for the intubation. Head elevation is important. And lastly, don't forget about DVT prophylaxis because the high risk of DVT by immobility. Regarding other systems, the GI, of course, because of autonomic dysfunction, also patient may have ileus or gastroparesis, and usually you require most of the time giving daily suppositories, and also you should minimize the use of opioid as much as possible because of the ileus. As we mentioned, if we see like urinary retention and incontinence in the beginning, first days of the GBS, it can be a red flag, but in the course of the disease, you can see these symptoms, and of course, you should do the catheterization for that. Regarding the endocrinology, SIADH is one of the complications of the GBS, and if you saw evidence of a drop in sodium, you should consider this diagnosis, give the fluid restriction and hypertonic saline. And lastly, we talked about the DVT. The critical illness, neuropathy, myopathy can complicate even further the cases with GBS, that they have the prolonged hospitalization in the ICU, because long after staying in the ICU for weeks, you may ended up to have a combination of the neuropathy from GBS and critical illness neuropathy, which is gonna make the management of the disease more complicated. So regarding the treatment, it hasn't not been changed since my medical student years, 90s. Two main treatment for GBS is IVIG versus plasma exchange. The study shows not much difference about efficacy of these two. However, the selecting which one is based on the clinical criteria and also the availability of the medication. Here we use mostly IVIG than plasma exchanges because it's easier. It doesn't require like large catheter, and it needs a shorter course for the treatment. The way we give it, like it's the total dose of 2 grams per kg divided in 5 days. So each day 0.4 gram per kg per day. For plasma exchange, 5 sessions of plasma exchange, almost 3 liters every other day, or in some centers also they can do it daily. The main concern about IVIG is the people with the IgA deficiency may have like anaphylactic reaction. So some centers do check the IgA level before starting the medication. The main concern about plasma exchange is like venous catheter related infections, and transfusion-related acute lung injury. So there are a study that compared, as we mentioned, there's not much difference between IVIG and plasma exchange therapy. So they found the combination of both therapy also regarding the efficacy is as same as the IVIG or plasma exchange by itself and alone, and is not gonna change the prognosis of the GBS. So there is not much room for combination therapy based on this study. So as you also probably know, there is other GBS variants like AMAN, like acute motor axonal neuropathy, acquired and acute motor sensory axonal neuropathy. There is a Miller-Fisher variant, which is like 5 to 10%. Patient comes with like triad of areflexia, ataxia, and ophthalmoplegia. We have Bickerstaff encephalitis that basically is combination of the peripheral nerve and central nerve involvement. Patient comes with alternation in consciousness, some changes in hypersignal changes in brainstem, and these patients actually have paradoxical hyperreflexia. At the same time, they may have this neuropathy in lower in PNS. So the other variant is pharyngeal cervical brachial motor variant, which basically is, the study is different, but 3% of GBS can present with this, like a patient may come with ptosis, facial and pharyngeal and net flexor muscle arm weakness. As you see, this is very similar, especially the part with ptosis and facial muscle weakness can be misdiagnosed by myasthenia gravis. Usually spare legs and usually involves the arms more than legs. There's a paraparetic motor variant, which is like isolated leg weakness, and then pure sensory ataxic and autonomic variant. So let's shift the gear and talk about the CIDP. My main focus is gonna be CIDP, and like I just wanted to mention about GBS on the beginning of the slides because it's more emergency. But what's CIDP? It's like chronic inflammatory demyelinating polyradiculopathy. By definition, it's at least the typical CIDP is a symmetrical muscle weakness, more prominent weakness, more prominent than sensory. And as we mentioned before, progressive weakness for more than 1 month before plateau. Then the other prominent finding in exam is areflexia, same as GBS. There are two main format of progression. Either is relapsing remitting, which is basically mostly patients between second and fourth decades, they can present with this type, and then there is a slowly progressive form that stepwise progressive, which is basically patients with between 5th and 7th decade have this presentation. And as you know, like regarding the electrodiagnostic finding is demyelinating pathophysiology, and there's a potential responsiveness to immunomodulating medications that we're gonna talk about that. So what's not common, but it can be seen, facial or pharyngeal and extraocular muscle movements can be seen. It's not common, but cranial neuropathy can be seen in CIDPs. Autonomic dysfunction is not as common as GBS, but so can be seen. And only 20% of patients with CIDP, they have painful symptoms. So regarding the epidemiology, I want to focus on this slide for a second, because in general, if we talk about definite or probable neuropathies because of the diabetes and so many other common, like alcohol overuse association with neuropathy, there are estimations that based on the population, but in general, there is 9.4% of the whole population has some form of neuropathy, either with definite or probable diagnosis. But among this 9.4% of the whole population, if you look for the incidence of CIDP, it's just almost 2 every 100,000. So I wanted to show you this slide to just tell you how rare this CIDP is. I know that most of people, when the patient comes with a progressive CI, like neuropathy symptoms, they think about CIDP, but because this is a very, very rare condition in comparison with other type of neuropathies, always you need to have at least, I'm not saying that you definitely sure this is 100% CIDP to start the medication, but at least a good amount of the information regarding the criteria and fulfilling the criteria to label the patient as a CIDP to start the patient on medication. So this is why every year the European Academy of Neurology and Peripheral Nerve Society guidelines changing regarding diagnosis of the CIDP. The last revision came in 2021, and I don't know how much you're familiar with the EFNS guidelines about the diagnosis of the CIDP, which before this 2021, I think the last one was in 2010. There are a few changes. First of all, they made it much, much simpler than before, because regarding the diagnosis of the CIDP, there was a definite CIDP, probable CIDP, and possible CIDP, and then the criteria of the electrodiagnostic findings were also was very different. Now they just simplifies it to the CIDP and possible CIDP. There is no more using the phrase like atypical CIDP. They just mentioned typical CIDP versus CIDP variants. And in the previous guidelines, sensory nerve conduction study findings were part of the supportive criteria for the diagnosis. Now they put it in electrodiagnostic criteria. And basically, I'm going to show the slides. The main difference between a definite CIDP with possible CIDP in a patient with the clinical presentation, it's if the electrodiagnostic finding, abnormal finding, it's in at least 2 motor neurons, then it's a CIDP. If it's in just 1 motor neuron, then it's going to be possible CIDP. And in patients with the possible CIDP diagnosis, regarding the patient comes with the typical clinical presentation, but not fulfilling the criteria for electrodiagnostic criteria, then they are using objective improvement with IVIG or plasma exchange or corticosteroid as another criteria to make it in category of definite CIDP, and or using 1 additional supportive criteria. So as we mentioned, when we are talking about criteria, there are a combination of 3 things, like clinical criteria for CIDP, then electrodiagnostic criteria. If 1 patient have both of them and fulfilling the criteria for clinical criteria. So for all CIDP forms, we start with clinic of the patient. If clinically doesn't look like CIDP, it is not. So even we don't care about other findings. But if it's clinical criteria is there, then we look for the electrodiagnostic findings. If the motor abnormalities you can see it in at least 2 nerves, and the sensory conduction abnormalities in 2 nerves, then you're done and you have your diagnosis. But if you have clinical criteria and motor conduction criteria only in 1 nerve, but again, sensory conduction abnormality in 2 nerves, then you are in category of possible CIDP. You can have a typical CIDP definite diagnosis if you have criteria with possible CIDP plus 2 supportive criteria, which we gotta mention about that in later slides. So as you see, we are like talking about the first typical CIDP, then the other forms of which we naming as CIDP variants, like distal CIDP means like the weakness is mainly focused on the distal part of the extremities and not much weakness in the proximal part. Multifocal or focal CIDPs, that's like a multiplex monoreitis multiplex involvement of the nerves in different parts and not symmetric. Motor CIDP, isolated motor symptoms without sensory abnormalities in nerve conduction study. But we talked about that clinical criteria is the most important one to have the diagnosis. What are these criteria? So as we mentioned, progressive and relapsing, symmetric, proximal and distal muscle weakness in upper and lower extremity, and sensory involvement at least in 2 limbs. The progression over 8 weeks and areflexia. These are the typical CIDP. Then we have the CIDP variants, as I mentioned. These are distal CIDP, multifocal CIDP, focal CIDP, motor CIDP, and sensory CIDP are the CIDP variants. So what are the motor nerve conduction criteria based on this new revised guidelines? So they put it like as strongly supportive of demyelination, weakly supportive of demyelination. So what is strongly supportive of demyelination criteria is like if patient at least have one of these 6 things that I'm mentioning, actually 7. If the prolongation in distal latency more than 50% of upper limit normal, at least in 2 nerves. Here we're excluding the median neuropathy because of carpal tunnel syndrome, of course, can do that. And if you saw just in the median nerve, may be related to carpal tunnel syndrome more than CIDP. Then, of course, reduction in conduction velocity, more than 30% below lower limit normal in 2 nerves. Prolongation of F latency, more than 20% of upper limit normal in 2 nerves. As you see in this strongly supportive, it's 2 nerves is the key. If we have the same finding in nerve conduction study, but it's only in 1 nerve, then it's gonna be weakly supportive of demyelination, the criteria. Of course, the absence of the F waves in 2 nerves, but the key point here is that you should have at least a distal negative peak CMAP amplitude more than 20% of lower limit normal to consider absence of F wave as a criteria. So for example, if the CMAP amplitude of pronal nerve is 2.5 millivolts in like normal people, and you have a patient with a CMAP amplitude of 0.25 millivolt, you cannot comment that absent of F wave consider as a abnormal criteria for CIDP. So then the other criteria is the motor conduction block, which is more than 30% reduction in CMAP amplitude in proximal versus distal stimulation. Here we excluding the tibial nerves because the reduction, more than 30% reduction in the CMAP amplitude of the tibial nerve can be physiologic. And again, here we need to have a distal negative peak CMAP amplitude of more than 20% of lower limit normal in two nerves to talk about conduction block. For example, again, in the previous example that I mentioned, for example, if it's a fibular nerve, CMAP amplitude, which is like normal ranges, is above 2 millivolt. It's above, instead of 2, it's 0.2 millivolt in distal stimulation, and it comes down to 0.1 in proximal stimulation, even though the reduction is almost 50% and more than 30%, we cannot name it as a conduction block. And you require to have at least CMAP amplitude of at least 20% of lower limit normal. And then we have the abnormal temporal dispersion increase, more than 30% increase in duration of the wave between proximal and distal stimulation. And of course, the distal CMAP duration, sorry, which is depending on the nerve and the lower frequency filter, you have the numbers here. And it's calculated between the onset of the first negative peak to return of the baseline. So what's the sensory nerve conduction criteria? Okay, so for CIDP, sensory conduction abnormalities can include the prolonged peak latency or onset latency, reduced snap amplitude, or low conduction velocity outside of the normal limits in two nerves. What's possible CIDP? I'm so sorry. Possible CIDP is the same finding instead of in two nerves in one nerve. There's a point here I just want to mention about the sensory CIDP. So when we are talking about the criteria for CIDP diagnosis, typical CIDP, we mentioned that you should have electrodiagnostic criteria at least in two nerves for motor and sensory. But for sensory finding, we don't have so much specific criteria. Any kind of abnormality actually can be considered as an abnormality. But when you're talking about pure sensory CIDP and your motor nerve conduction variant, then you should have either of one of these two things to name it as pure sensory CIDP. First criteria is if the nerve conduction velocity is less than 80% of lower limit normal, if the patient have snap amplitude of more than 80%, if the snap amplitude is less than 80%, then conduction velocity below 70% of lower limit normal, at least in two nerves, including median, ulnar, radial, or sural nerve. And the second criteria is the sural sparing pattern, means you have an abnormal median and radial sensory nerve action potentials amplitudes with normal sural snap amplitude. So supportive criteria for possible CIDP, as we mentioned, if you have possible CIDP criteria in electrodiagnostic criteria instead of two nerves in one nerve, you should gonna need a supportive criteria to have the definite CIDP diagnosis. What are those criteria? A response to treatment added in the supportive criteria. So the point is here, the key point here is that patients should have an objective response to treatments. Mean, if patient comes to you and says, oh, I'm feeling much better after receiving my IVIG, and you should be very specific what kind of better. Is it just like it feels better? It's like pain is improved. It's not part of the response to treatment. You should see something change in your exam to name it as an like improvement in the symptoms. Because most of the patients, to be honest, after receiving IVIG, they may feel better, but it doesn't mean necessarily IVIG is working. Then we're going to talk about that more in later slides. They put the imaging finding and the supportive criteria for possible CIDP, including ultrasound and MRI. So for example, in ultrasound, the cross-sectional area measurements for median nerve, more than 10 millimeter square with forearm, more than 13 in upper arm, or the interscalene trunk, nerve root trunks, more than 9, or more than 12 for nerve roots when you're doing the ultrasound, can be considered as a supportive criteria. Then after those CSF findings, protein cell dissociation, and lastly, nerve biopsy. So in the CSF analysis, if you use the cutoff, you want to use a cutoff of, by definition, what's the elevated CSF protein means. Maybe you should use a different cutoff for patients under age 50 versus patients over age 60. So for under age 50 young patients, the cutoff should be 0.5 gram per liter. For patients, elderly patients, above 0.6 gram per liter should be a good cutoff. If patient presents with more acute or subacute onset like symptoms, we should consider to do the CSF analysis to rule out other possible etiologies in differential diagnosis, especially infectious and malignant etiology. And also lastly, in the patients that they are diabetic, just be careful about the interpretation of elevated CSF protein, because diabetic patients also may have slightly elevated protein levels in the CSF. So now shifting gear to CIDP treatment. So there are different types of treatment. Main 3 treatments that's FDA approved are the corticosteroids, plasmapheresis, IVIG, and more recently subcutaneous immunoglobulin or SCIG. Never treat the patient pain with immunotherapy. So as we mentioned in the previous slide, when we are talking about objective response to IVIG or plasmapheresis, we should measurable tool. One of the tools that I prefer to use when checking for efficacy of the treatment is the INACT disability score, or inflammatory neuropathy cause and treatment disability score. There is a scoring between 0 to 5 for arm disability and leg disability. For leg, it's very obvious. For example, you score 0 if walking not affected, if walking affected, but still patient able to walk outdoors independently, scores 1. If using the unilateral support, just like a stick to walk, then they score 2. When using bilateral support, like crutches to walk outdoor, or then it's 3. If patient is using wheelchair to travel outside, but able to stand up and walk a few steps, the score is 4. And then basically 5 is just wheelchair bound. The same disability scores for upper extremity. Then in upper extremity, 3 main function is important: doing the zippers and buttons, washing or brushing hair, and using knife and fork. and also handling small coins. These are like related to fine motor movements, some of them in the distal hand. And if patient have any of these limitation in any of these movements, can increase in the getting scores, and combination of these two, like leg and arm disability, can give us like a maximum of 10 for the worst case scenario and 0 for best case scenario, which basically patient is asymptomatic. So we talked about the treatment for CIDP plasmapheresis is still for, at least for induction therapy in the beginning of the symptoms, still can be a good replacement for IVIG. But as we mentioned before, it requires a central venous catheter placement, and you should be careful about catheter infection and also side effects of the plasmapheresis, including hypocalcemia because of the high citrate, and also thrombocytopenia and anemia. So for IVIG treatment, have you see the patients who had a relapse in the placebo over the like 24 weeks, maybe around 50% of the patients had like a relapse without receiving IVIG, but patients who received IVIG, this relapse rate was much lower. It's almost 10%. So how we treat the patient with CIDP with IVIG, there is no specific instruction. There is some recommendation based on the EFSN guidelines, but there is no doubt about induction therapy, which always we start with total dose of 2 grams per kg. It can be divided in 2 to 5 days. If the patient's the first time using the IVIG, it's better to be in 5 days. So every day is gonna be 0.4 grams per kg. We wait for 3 weeks, assess the patient. If the patient's symptoms gone, which is very unlikely, just with one single treatment, it's gonna be the scenario, then you're done, wait and monitor symptoms. If still after 3 weeks, patient symptomatic, then it's gonna be 2 options. In this approach, we do the second optional dose of the same 2 grams per kg, then reassess the patient, and whenever patient stabilized and you see the reduction of the symptoms and improvement, increase the interval between the IVIGs or lower the dose of IVIG each time 20% per course to see is lower IVIG dose is as effective as the high dose. This is one of the approach. But as I'm gonna mention in new criteria, they are recommending induction therapy with 2 grams per kg, and then if patient needs a maintenance therapy, the recommended dose is gonna be 1 gram per kg every 3 weeks. I'm so sorry. So if you're comparing the doses, 0.45 gram per kg versus 1 gram per kg versus 2 gram per kg, as you see in the beginning of the symptoms, maybe almost the same efficacy in reduction of the recurrence of the symptoms or progression of the disease. But as a secondary outcomes, when you're checking in week 24 for the patients that receive the higher dose for induction, they have 92% responded, but versus the mid dose 1 gram per kg, 80%, and low dose is just 0.5 gram per kg, 65% or responders. So this is why, based on this study, they recommended the maintenance dose at least should be 1 gram per kg per day. We talked about the subcutaneous immunoglobulin. The study shows that they are not recommending for induction therapy, but For maintenance therapy, you can suggest if the subcutaneous immunoglobulin is available for maintenance therapy, but the treatment should be weekly and either 0.2 gram per, or I'm going to mention about the doses. So EFNS guidelines for treatment of CIDP, they're mentioning that both IVIG and oral or IV corticosteroids should be considered as a first line of the treatment. Strongly recommending treatment with IVIG or plasma exchange as an induction therapy. And when we can say that patient is in the category of being unresponsive to IVIG, if one of these two things, you give the induction therapy, reevaluate 3 weeks, patients still weak, and continue maintenance therapy for 2 to 5 every 3 weeks for 2 to 5 times, and you see no objective improvement, then you can conclude this is not a patient that's responsive to IVIG, and you don't need to continue IVIG. Or you should give the first 2 gram per kg, and then after a few weeks, the good second induction therapy, and after that, no improvement, then you can conclude this is not a responsive medication patient. Sorry. So what's the EN guideline for corticosteroid treatment? For induction and maintenance therapy, either we use the daily prednisone, which is like 1 milligram per kg per day, or 60 milligram per day, or and then slowly tapering it down based on the response of the patient. If we use the IV, we can use IV prednisone, methylprednisolone, 500 milligram per day for 4 days, and repeat that every month, at least for 6 months. Or we can give high dose oral dexamethasone, 40 milligram per day for 4 days each month, and just repeat it for 6 months. Because of the concern about the corticosteroid side effects, long-term use of the corticosteroid is not recommended. And if the IVIG is accessible, I think this is my personal approach. I prefer using IVIG maintenance therapy over corticosteroid, but if it's not available, it's a very good option. So as we mentioned before, the new guideline most commonly used IVIG maintenance regimen as a 1 gram per kg every 3 weeks. So for subcutaneous immunoglobulin, which we mentioned before, the recommended dose is either 0.4 gram per kg weekly versus 0.2 gram per kg weekly based on the patient's response to treatment. They have a open label extension study like until 24 weeks in the patient that they switched their IVIG to subcutaneous immunoglobulin, and there was not much difference between relapse of the symptoms between these two groups, and they concluded at least maintenance therapy with subcutaneous immunoglobulin as effective as IVIG maintenance therapy. So when we decide to choose between subcutaneous versus IVIG, actually this was a very big topic during the COVID infection, because most of the patients that they were on maintenance therapy, they didn't have the chance to go to the hospital because of the COVID infection, and there was a trend to using more subcutaneous immunoglobulin because it's something that can be done at home. It just requires some training to the patient. Patient can do it by itself after a skilled nurse like train her to do it at home. And also it lacks the adverse effects of the IVIGs like headaches or like flu-like symptoms. It may happen, but it's much less than the IVIG form. And let me see here. Okay, so when we name it as a like patient, imagine patient comes with the CIDP, you diagnose patient with CIDP based on the criteria, you start induction therapy and continue maintenance therapy, and patients stabilize, have a response to treatment, it's improvement of the symptoms. When you decided to stop the maintenance therapy, this is a big issue here in the United States. The people with CIDP, we have cases that minimal like symptoms of CIDP, like very mild weakness, distal or mild sensory symptoms, still they are continuing IVIG maintenance therapy for more than 5 years. There is no like much study done about when it's the right time to discontinue maintenance therapy, but the main recommendation is like once every 6 to 12 months, like means once or twice a year, patients should be checked after in the first 2 to 3 years of the treatment. And then whenever you see that patient's clinically stable, then think about reducing the dose of IVIG. Like, for example, if it's some patients on 1 gram per kg maintenance therapy, to reduce it to 0.8 gram per kg. And again, these are the main recommendations that we already talked about for most of those in previous slide. I just wanted to mention about this rituximab. There is no concluded large study. Still, there are some studies about using of rituximab in the intractable cases of CIDP may help. And the preliminary study shows the efficacy of the medication. Rituximab is a medication, monoclonal antibody against CD20 marker. And regarding what about the other medications? So they did large studies about interferon, methotrexate, fingolimod, which is like the medications that mostly used in the central forms of like demyelinating like MS. There are evidence strongly against using interferon beta, also weakly against using methotrexate and fingolimod. So not these 3, but other 5 medications, azathioprine, cyclophosphamide, cyclosporine, and CellCept and rituximab. There is some evidence, it's not as strong, but it's like some weak evidence in favor of using these medications in the cases that they are not responsive to IVIG plasma exchange or corticosteroid. So when we usually use these medications are either as a corticosteroid sparing agent, or in cases of as we mentioned, patients not responsive to IVIG or plasma exchange. I have so many slides left, but I think regarding the time, may I ask how much time I have left?
I think you can go on for a few minutes. We still have time.
Okay, so I just wanted to shift the gear and talk about, like, we already talked about the different forms of the CIDP variants, but there's an entity here named DADS, or the form of the distal neuropathy, which is distal acquired demyelinating symmetric neuropathy as an abbreviation for that. The point is, like, these are the form of neuropathy that's mainly associated with gammopathies, and most of the gammopathies, like patients with MGOS, they have IgM. And in some studies, 70% of the patients, they have antibody against MAG, myelin-associated glycoprotein. And why it's important to identify this like neuropathy versus CIDP, because most of these patients, especially the ones that they have an association with blood malignancies, they don't have a good response to therapies that we use for CIDP, especially IVIG, prednisone, or corticosteroid. But the forms that they are idiopathic and can be considered, as we mentioned, distal variant of CIDP, can be considered as that, like idiopathic form versus the one that associated with blood malignancy, the treatment is going to be different. There is an electrophysiologic criteria for diagnosis of that, which is basically uniform reduction in conduction velocities, but more disproportionate prolonged distal latency, like by the definition, terminal latency index, which is calculation of the distal velocity divided by intermediate velocity of the nerve, is less than 0.25%. What it means the main slowness of the nerves is in distal part of the nerve, and this is causing very prominent prolongation in distal latency. For example, you can have a distal latency of 8, 9 millisecond, 10 millisecond in upper motor nerves. That's the main thing about that, while when you're calculating the velocity of more proximal parts of the nerve, you may end up having normal conduction velocity. IgM-associated neuropathy, as we mentioned, they have association with gammopathies, blood malignancies, and because they are poorly responsive to IVIG plasmapheresis, rituximab should be a consideration for treatment of these patients. Also, in these new criteria, they put this CISP, which is basically a chronic inflammatory sensory polyradiculopathy. They didn't put it in as a CIDP variant in 2021 revision. CISP is different from pure sensory variant of CIDP, because in the pure sensory variant of CIDP, we still have abnormal sensory nerve conduction study. But in CISP, which is this basically chronic inflammatory sensory polyradiculopathy, normal conduction velocity, when you're checking the routine test, it's normal, but patient have an abnormal SSEP, means more proximal parts of peripheral nervous system has the involvement. But these patients also are responsive to immunotherapy, and it's very rare condition. So there are other forms of the neuropathy, and the patients comes with the weakness. Some of them can be considered in differential diagnosis of CIDP, as you know, MMN, multifocal motor neuropathy, which have the association with GM1 antibody. It's basically slowly progressive distal weakness of hands and feet, not very symmetrically, can be different nerves in different extremities, and the main finding in the nerve conduction study is a conduction block, but the patient have a normal CSF test result. And the thing about a multifocal motor neuropathy, the treatment of the choice is IVIG, because patient usually is not responsive to corticosteroid or prednisone. I wanted to show like multifocal motor neuropathy versus MATSOM, which is the multifocal form of
Thank you, Dr. Mohammad Khanli, for your great presentation. It was very informative and a comprehensive review of the topic. I have received a few questions, and I have questions of mine, and I'll ask them one by one.
Sure.
And have your opinion. The first one is about plasma exchange. You mentioned that we usually perform plasma exchange every other day.
Correct.
And in 5 sessions.
Correct.
So are you aware of any study that has compared the alternate day exchange with daily exchange? And why do you think the alternate exchanges are preferred to the daily exchange?
I think it's mostly is based on the tolerance of the patient, and that because one of the side effects of the plasmapheresis is also increased in the citrate level, and alternated, like I'm sure there's no big studies about comparing, and here also center by center is different. And my residency in George Washington Hospital, we usually do it daily, and most of the patients was tolerating it like very well. Right now in City of Hope, they prefer to do every other day. I'm guessing because some patients are like cancer patients that we are seeing with the CIDP, like they are more delicate and they want to make sure it's not gonna be like hyperviscosity syndrome, this problem. But I think mostly depends on the tolerability of the patient, and there's no studies at least showing that if you give it daily, it's gonna be less effective than every other day. But the EFNS came with this like recommendation that 5 sessions, but in the like just the main thing is 5 sessions of the plasma exchange, but they didn't recommend it's daily or every other day. Just mentioned in the text maybe every other day is better approach, but they didn't explain too much about why we cannot do it. Like, I'm guessing if this they are concerning about maybe the tolerability for patients is going to be easier if it's every other day than daily.
Yes, we'll probably have less complications if we do
Yeah.
it every other day, but and for patients with GBS that have a more critical situation and should probably stay in the hospital for a longer period of time, it's better to do it. And also they have autonomic dysfunction, maybe blood pressure drops, hypotensive episodes. So it's better to do it alternate day. But then we have patients like CIDP that we want to use a plasma exchange as induction therapy, and we prefer a shorter stay in the hospital, or probably we can manage it as an outpatient treatment. I don't know if you recommend it or not, doing
So to be
plasma
honest,
exchange at
I have very little experience about plasma exchange because IVIG is very available here. So always IVIG is the first choice here. It's much easier, like faster starting, like they don't need a central catheterization. Like, so it's much easier to use. So that's why we use just plasma exchange if we don't have a good response to IVIG, which basically based on rarity of the CIDP and then not being responsive to, it happens very rarely to like use plasma exchange. So to be honest, I don't have too much experience about. I'm sure you're much more experienced using plasma exchange. I guess at least the times that there was some IVIG deficiency I heard was like there in Iran. So is it still going on or?
Yes. We currently have a shortage of IVIG, and we have great difficulty maintaining the IVIG injections monthly or so on, IVIG injections regularly. So we sometimes have to manage with plasma exchange and corticosteroids. And another question that I have is about corticosteroids. The problem with corticosteroids is that we have many complications in long-term corticosteroid treatment. And another oral corticosteroid treatment. Another alternative is the IV injection or pulsed or intermittent dosing of corticosteroids. As you mentioned, like dexamethasone 4 days in a row each month, or IV methylprednisolone every 2 weeks or 3 weeks or 4 weeks. Do you have any experience with this pulsed corticosteroid therapy in CIDP, like pulse methylprednisolone 1 gram every 2 weeks, and the long-term management? Do we have less complications using the IV injections compared to the oral ones?
At least based on the guidelines, again, there is not much study done to compare between these two regarding the corticosteroid. personally, in favor of like pulse therapy every month. Then like if the patient's gonna require like longer treatment, but sometimes it's not convenient for patient to come to the hospital or at least infusion center to receive, if it's like a methylprednisolone every month for like 4 days. So they prefer the oral medication. So most of the times I leave the decision to the patient. I offer both of the treatments, but in general, this is my like experience. I think I see less side effects in the pulse therapy than if the patient's done like long-term, very like over the years on the steroid therapy, especially if you keep it in the higher dose. You had to keep it in a higher dose and you don't have a chance to taper it down in early like stages of the treatment, ended up to have more complications.
Okay, thank
But
you.
it depends on if the patient really like to go to an infusion center to receive the IV methylprednisolone monthly, like in pulse form for 4 days.
Okay, great. So I'll continue with the questions that I have received. Meanwhile, if the audience have questions, please put it in the chat box so I can ask Dr. Khanli your questions. So I personally have a problem with the CIDP electrodiagnostic criteria, and that is in all parts they talk about two nerves. Yeah. Like two nerves having increased distal latency, two nerves having conduction block, two nerves having temporal dispersion, two nerves having slowing of conduction velocities.
Correct.
And in practice, we come across patients that have increased distal latency in one nerve, conduction block in another nerve, increased F-wave latency in another nerve, because CIDP is segmental. So you can have increased this latency in median, in reduced conduction velocity in ulnar, and so on. So why not adjusting the criteria so that if a patients have only one conduction block or one increased distal latency, we can put these together and make the criteria work?
Yeah, I think you're completely right. Like these criteria, as you see, like, I don't know if you seeing my slides, it says at least one of the following. So if you have reduced conduction velocity, that's done. You have your one nerve, like for example, in ulnar nerve, you have a reduced conduction velocity, and then in other nerve, you have a prolonged distal latency. This is my impression. You have your all like two nerves, either though like it's a different nerves, but you have the two nerves problem, because I understand what you're saying. For example, the reduction velocity you see at least in two nerves, you just see it in one nerve, then you see in a conduction block in another nerve. Then you go to the weakly supportive of demyelination, and for the still CIDP is in possible CIDP category. And if you can add supportive criteria like CSF, for example, elevated protein level in CSF, you check, it's one of the easiest thing, then you have your criteria and diagnosis of CIDP. Or you do the ultrasound and you have like increase in the diameter of the nerve roots, then you have like, if you see these changes in just one single nerve, then you require a supportive to be changed to like definite CIDP diagnosis from possible.
Yes, thank you. Another question is about nodopathies. You don't have to.
Yeah,
comment
I
on
actually have a couple of slides here. I really wanted to show these because this is a new entity, and they in the 2021 revision, they take this out of the classification of it's not anymore a CIDP variant. It's a separate is it okay if I show like these slides?
Yes, it's slide 49.
Yeah. Okay, so this is also again UFNS like a recommendation guideline for nodopathies. As we know, like there are multiple antibodies identified in some forms of the CIDP, especially the ones that they were resistant to standard therapy or have an aggressive onset to like a presentation, or mainly the symptoms were like sensory ataxia, tremor, or even cerebellar type symptoms. And also the patients have more respiratory failure and cranial nerve involvement than other typical forms of the CIDP, and very high levels of protein, CSF protein. So in some of these are the clinical features that can be different in nodopathies versus the typical CIDP, and the antibodies that we usually check. And now strongly the guidelines recommending considering if it's these antibody tests are available to be tested are anti-NF155, anti-CNTN1, and Casper1. And they also added recently NF140/186. These are the antibodies for nodopathies. Why it's important? Because if you have these antibodies and you're not suspicious of nodopathies, then we should consider rituximab as the main treatment versus the IVIG or plasmapheresis. And as we mentioned in the previous slide, they have more acute onset symptoms, and the ataxia and sensory symptoms are much more commonly seen, especially tremor in the forms of that associated with anti-NF155 and CNT1. And in the patients with the antibody against Casper1, they have more prominent pain. But as I mentioned, in the revision, they didn't put it as a CIDP variant, and they put it like as a separate entity.
Yes. The problem here is that we don't have the antibody panel available in Iran right now. We used to send the samples to Germany, a reference lab in Germany, but there was a problem sending the samples, and now we don't have it. So we just have to rely on the clinical features, as you mentioned, people, CIDP patients resistant to IVIG or corticosteroids, those have acute onset CIDP, have tremor, and if we come across these patients, we move to rituximab. And in my personal experience, there's a 50% chance of responding to rituximab in our refractory CIDP patients.
Yeah, that's very accurate. Actually, there are so much, like at least the studies is under, like right now, the studies are going, like it's like showing the efficacy of rituximab in the patients with, they are intractable to classic therapy like IVIG or plasmapheresis. So most of the studies, even though in the previous criteria, like there was like not much evidence behind the rituximab, every day new studies coming, they are in favor of rituximab therapy. Definitely in case of nodopathies, but even in the CIDP forms are the refractory to IVIG or plasma exchange. So, and the antibody testing, I know it's an issue, even if it's an issue here, because most, like, it's like all of the centers have these antibodies. We ended up to say these, if a patient need these tests to just the 2-3 centers in US, like Mayo Clinic or Washington. So actually I had a slide here that it's not just those antibodies. Every day they're coming up with a new disease, with a new antibodies. So like, and then even like they're giving us this, like, I don't know, you attending this AM meeting, they give us like, okay, so if your patient comes with this small fiber neuropathy symptoms, you should check this. And, but at the end, what I'm thinking about, how much important checking of these antibodies for each person, and what's the indication? Because first of all, it's not cheap for the patient. Most of the insurance is still not covering it even here. So I totally agree with you. If you have your CIDP diagnosis and the patient's responsive to treatment, there is no need to check these antibodies. But if you have a refractory case, then you should shift gear and think about other diagnoses, and then you may consider sending other tests to make sure you're not missing anything else. I am working at like comprehensive cancer center, so I may see more paraneoplastic like neuropathies than other centers, even more than CIDP for sure. But again, we have some panel for paraneoplastic antibody panel. We usually, if the patient comes with the neuropathy symptoms, especially sensory neuropathy symptoms, we send this panel, even though maybe some antibodies, they have more association with sensory neuropathies than the others. Again, this antibody testing, it depends on the availability of the test and how you decide to use them. But of course, there are a couple of recommendations. For example, checking MAG antibody. It's very necessary for patients that have neuropathy association with IgM MGUS, monoclonal gammopathy with the M protein of IgM. I definitely check anti-MAG for those patients. If I'm suspicious to multifocal motor neuropathy, I definitely check GM1. If I'm suspicious to paraneoplastic, then I check ANA1 and ANA2, like the other ones. Depends on the patient and the availability of the test, I can say.
Okay, thank you. So there are many issues remaining, and you didn't have time to cover all the different neuropathies in this session. We will definitely need another session to discuss the remaining issues like paraneoplastic polyneuropathies, paraproteinemic neuropathies, POEM syndrome, and other types of neuropathy. I hope, I know you're very busy, but I hope you will give us another chance in the future to have you and with another webinar on other types of neuropathy.
Definitely, it would be my pleasure. So like, I'm so sorry, I was slow in the beginning of the presentation. I was hoping to at least to talk about the paratonemias in this session, but I don't know, like we had
a very hard topic, especially discussing the EFNS criteria, the electrophysiologic criteria is very difficult.
But because of also, like, as I mentioned, I didn't know who are the audiences. I'm so sorry to stay calling from the hospital.
Oh, yes.
I wanted to like have this more explaining to the people, maybe that they are not very familiar with these criteria.
Okay, thank you very much, Hadi. I would also like to thank you, the Office of International Affairs of TUMS, and also the audience for attending this webinar. Thank you very much and goodbye.
Thank you so much, everyone. Thank you.